Welcome, everybody, to our ECI webinar this month. We're happy to have everybody join us. My name is Kelly Williams, and I'm the ECI committee chair and also moderating our first case. We'll have two great cases today. One from that's going to be represented from my university at Medical University of South Carolina, and then Tamar, Rubin, one of our other ECI members, will be presenting the second case. So for just a few quick reminders, one, the annual meeting registration has just opened, so feel free to register. The pre-conference agenda was also recently added, so if you wanted to check that out. And then two, late-breaking abstracts are currently, submission is currently open for those. Okay, so we'll have two cases, and at the end we'll have a very brief review of a hot article that just came out. Okay, our first case is going to be presented by our second-year pediatric resident, Adam Bartholomeo. He is interested in allergy, immunology, and rheumatology, and we don't have fellows here, but he is fellow material and quality. And so I'm happy that he was happy to present this case for everybody today. And we have Dr. Louise Markert for our senior expert and mentor. Okay, Adam, you can start.
Wonderful. Thank you so much, Dr. Williams. Really excited to be here tonight. So I guess to jump right in to get into our case. So this is a case that originally started workup over in UCLA and then kind of transitioned over to MUSC when they moved. So this is a 5-day-old male referred to immunology clinic for abnormal TREC. It was a full-term standard vaginal delivery. The pregnancy was complicated by poorly controlled gestational diabetes. Postnatally was found to have a right brachial cleft cyst and horseshoe kidney. Newborn screen was positive for TREC, which prompted immunology referral. Of note, on day of life 5, he was admitted to the local hospital for seizure activity and found to be hypocalcemic. Subsequently started on calcium supplementation and calcitriol that improved. Incidentally, he was found to be positive for coronavirus, not COVID-19, during that admission as well. All right, let's see, button.
Adam, there's a quick message if you could just increase your volume or try and speak louder.
Absolutely. Let's see. Can you hear me now? Better?
Yeah.
Perfect.
That's excellent.
Okay. Day of life 14, he was readmitted for recurrent seizures, found to have very low calcium levels that were refractory. Calcium and calcitriol were adjusted and no further seizures. He developed some superficial phlebitis at that time after IV calcium infusion, and also was positive for rotavirus. Otherwise, growing and developing well. So kind of with this initial presentation, for a differential diagnosis, SCID, whether ADA or adenosine deaminase deficiency, Serranos DNA ligase 4, RAG1, of course with the hypocalcemia, thinking DeGeorge syndrome, as well as PMP deficiency, ataxia, telangiectasia, and Niemann-Brigid syndrome. So kind of with the brief story that we know thus far, kind of opening up to attendees, is there anything else at this point that you would have on the differential diagnosis or anything that would come to mind?
We'll give them a few minutes. I'll look to see if anybody has any suggestions in the chat, Adam.
Sure.
This was the differential that we came up with, but of course, seizures and an abnormal TREC. Does that spawn any other ideas for people? Always charge in the differential, which is a good one as well. Someone's asking if there was any microcephaly, and Adam's going to get to the presentation, but there was not any microcephaly. Anything else? Charge is definitely a good one to add in there.
Okay. So kind of continuing with our case for some more information. I see Roifman syndrome as well, added to the differential. No known family history of immune disorders, leukemia, lymphoma, no history of unexplained early childhood death, no history of consanguinity. Of no, mom type 2 diabetes. Unclear if she had it pre-pregnancy. She was diagnosed 3 months into pregnancy for the first time. She also has asthma, fatty liver, and a history of Hep C that was IgG positive, and an enlarged thyroid. Maternal grandmother had SLE and prediabetes. And then there was a maternal cousin that had convulsions in childhood, now on thyroid medication. Also history of immune problems and behavior problems. Not much else known about this cousin. Dad, though, completely healthy and really unremarkable history on his side. Initial pertinent lab evaluation, TRECs were repeated and remained abnormally low. Looking at our T cell population, CD3, CD4, CD8 were all low, but normal B cells and NK cells. Interestingly, of note, the naive T cell population robustly positive for production, so 72% and 99%, even though we have low T cell population. Looking at the rest of the CBC, pretty unremarkable, except for some mild elevated platelets and an ANC of 1410 that was flagged as normal. Some lymphopenia, and mitogen proliferation in PHA, and for PWM were both normal as well.
Yeah, sorry, we don't have actual counts there. That was done at the outside hospital, but they don't actually give us the CPM, but those were the percentages, and then the proliferation was normal. And overall, reassuring naive to memory ratio. So how do people feel after seeing these initial labs? Anything in particular from our differential that goes up or goes down? I also suggested a Ph1, which is seizures, cortical blindness, and microcephaly syndrome. APISA was also suggested in Roifman. Anything else now with this T minus, B positive, NK positive, but with reassuring T cell function and ratio?
Well, I'll just, this is Louise Markert, say the mitogens can be positive for all sorts of folks who have immune deficiency, and the George patients in particular. So that's not particularly helpful. And I'll save my comments on the naive numbers for a little later.
Okay, great. Thank you. Amit was asking about ADA activity in PNP, and we don't have those data, and they aren't done directly on the dried blood spot. At least this was done in California, but we don't have that ability, or I don't know. I usually send it to Duke for ADA. Okay, Adam, you can continue.
Awesome. Initial genetic evaluation, the microarray was normal, including 22q11 and 10p13 hemizygosity, essentially ruling out our complete DeGeorge syndrome. Hypoparathyroidism panel failed to identify any pathogenic variants. And looking at our Invitae PID panel, failed to identify any causative pathogenic variants. There was a heterozygous pathogenic variant, MEFV, or familial Mediterranean fever, but otherwise are variants of unknown significance that are listed below. I know we're going to talk a little bit more about them later, but I don't know if we want to do more discussion.
Yeah, we're going to talk about them when we go back through to when we go over our whole exome, but these are the mutations, and we did not feel, based on looking at them, that they were likely targets, although we were really just relying mostly then to get the whole exome and hopefully find something, but then we really had to dig a little deeper. Clearly, the FMF gene is not causing this T-cell lymphopenia. So, and then someone's asking about low PTH, and that, yes, that was, the parathyroid hormone was low.
Awesome. Physical exam. This was the first physical exam by MUSC. Pretty overall very unremarkable exam. No dysmorphic features that we can see on exam, and pretty good for weight and circumference. We did notice some yellow scale and dandruff noted in the scalp. We did do a fungal culture, and this was negative. Case continued at age 6 months, followed up with immunology. He was noted to have some diffuse mild atopic dermatitis, face, trunk, all extremities, started on low-dose topical steroid and immunomoisturizer, which improved the atopic dermatitis. Mom also reported new posterior occipital and right anterior cervical lymph nodes that were present for about 2 months, but would increase and decrease in size.
And just a comment, but at least from the notes there, it seemed like it was small, shoddy, but increasing, decreasing reactive nodes. Not anything significant like lymphoma-like. No, there was no skin biopsy done. So for concern of maternal engraftment, which Adrian was asking about, the rash, the pictures that I was able to see looked very much like a mild eczema. And, the first note said that they just needed a veno. So I don't think it was too significant. And then they added a light topical steroid. Sorry, and Terry, someone's asking, they said that BP was really high for a newborn. So this physical exam and this blood pressure was done when the baby was a little bit older. But
he was also screaming his head off when that was done.
Yes. And the stature was small. No, I don't have his full growth chart, but he has always been on the smaller side.
And he seems to be tracking along that 1 percentile consistently.
Yep. All good things to note too. Okay. You can continue.
Perfect. Going into infectious history, no bacteremia.
Sorry, I'm going to pause you, Adam. So from there, that's kind of the story of like before he moved. So starting here with the infectious history is everything from beyond. And basically COVID happened. He went to more of a quarantine and moved from California to South Carolina, where we assumed care of him. And these next few slides are all the summary of since we've been taking care of him.
Awesome. For infectious history, no bacteremia, sepsis, or meningitis, osteomyelitis. Pretty much only positive for like some recurrent viral URIs that were pretty self-limiting. He had a couple ear infections that cleared with the course of antibiotics. Otherwise, no other really significant serious bacterial infections as listed. He did have that rotavirus infection when he was in the hospital. Obviously, has not received the vaccine, but that was only one time. And did over several weeks.
His lymphopenia has not significantly improved, and yes, here's his nice trend.
The next slide. Perfect timing. Great segue. So kind of looking at his counts, his trends since birth until he was seen here at MUSC. On the left, I have the UCLA references and the MUSC references on the right. 21 months and 24 months were the MUSC data points. You can see that the lymphopenia for CD3, 4, and 8 are just persistently low. And pretty much for his naive percentages, as well as his pretty consistently high as well, which I know Dr. Markert will talk a little bit more about. But CD19 NKs all stayed steadily appropriate, as well as immunoglobulins and ANC. Absolute neutrophil count was normal.
I think Louise will talk here, but obviously people can see the trend. His total T cells really haven't changed much. His total CD4 cells and CD8 cells really haven't changed much, but the percent naive cells has only declined with time. And so I don't know if Louise, you want to segue into that, or
I can say I'm very concerned about this child. The naive numbers, and this is just CD45RA. It doesn't have 62L or CD31 involved. I mean, these are low numbers, very low. And now for a complete DiGeorge, we have published and said you have to be below like 50 naive cells. But the thing is, we actually transplant kids that are above 50, because if you're between 50 and maybe 200, what's going to happen to you is what happened to one of my early patients, is that you end up with all sorts of autoimmune disease and end up being rushed to the hospital 15 times and dying at age 20. So this is, to me, a very concerning patient.
okay. And that's why we wanted everybody's input, because I just keep watching him like a hawk, but at the same time, he looks good most times, but his numbers aren't really improving or reassuring, or aren't getting better, I guess is what I would say. So from here, I guess, we can talk about next steps with Louise toward the end.
Sure. Some additional evaluation, whole exome sequencing failed to identify any additional variants of concern. Of note, the RTEL1 was a variant of unknown significance, but dad also tested positive for that same gene, but he was clinically asymptomatic, no history of lung disease, skin hair issues, liver disease in the father at all. He's completely healthy.
I will say, I'll just add in there, Adam, sorry to interrupt you, but because the in silico prediction was saying it was damaging, the kid was small, so dyskeratosis congenita, we wanted to just be sure that, that wasn't something that we needed to, or we could easily ignore. So that's why they originally did the telomere length testing, which was normal, but on the lower end of normal, and then repeated again.
And it was normal, the lower limit of normal the second time as well.
Mm-hmm.
No duplication, single nucleotide variants or gene copy number variants detected. The antigen proliferation to tetanus was normal, and the thymus ultrasound identified a shadow.
And so Amit was just asking specifically about TBX1, which is what you were just talking about. It was sequenced, and there was nothing found for duplication or SNV or copy number variants there. And so, Louise, I'm interested for you to comment on this thymus ultrasound. I personally don't often do those, and I think it's because Jennifer Puck told me it doesn't matter if they make T cells; it doesn't really matter how big the thymus is. But when we inherited the patient, mom was under the assumption we were going to be serially checking thymus ultrasounds, and so I didn't know if you could comment on the practice of that and whether I should be doing that, or if you do that, or if it's useful.
Yeah, we do not do that. We follow the naive T cells, really, to see what's going on. And it is interesting that you have antigen proliferation to tetanus. I mean, that is something that is interesting. But anyway, you can keep going.
Awesome. So in summary, for what we have thus far, we have a 2-year-old male, abnormal TREC, found to have severe T cell lymphopenia, CD4 are greater than CD8, with a brachial cleft cyst, status post-repair, horseshoe kidney, hypoparathyroidism, hypocalcemia with history of clinical seizures, on calcium supplementation, now stable, with normal microarray and negative genetic evaluation to date. He's on his Spectrum, not on Flucon. We started on Synagis when he was transferred over to MUSC. Not on any IG replacement, given his normal IgG, minimal infections, and good response to inactivated vaccines. Obviously hasn't gotten any live vaccines, and we've referred him to genetics. The biggest question that mom had on her initial visit with us was kind of regarding future pregnancies. What was the chance this would happen with subsequent children? So we sent her over there for preconception planning. So I guess, with this summary, what would your top working diagnosis be, and any additional thoughts?
If someone asked about developmental delays, he does not have any developmental delays.
Normal.
Yeah, and so someone also asked, Tamar asked about Pjp prophylaxis, and so those are all great questions. And I think we inherited him on it, and he was never on Flucon, he was never on Synagis, but I got worried when I first met him and his numbers were going down, so I did not take him off his prophylaxis. But I have talked to mom about taking him off his Bactrim, but at the same time, I've been waiting for basically an upward trend of any of his naive numbers. And so, but yes, so maybe Dr. Markert wants to comment on in some of her DiGeorge patients, what you use as a threshold for Pjp prophylaxis, since they have normal mitogens, normal antigens in these counts.
Well, I would need to look over those data a little bit more, but it's very concerning. These are very low T cell numbers, and you really, with such low numbers, you tend to end up with all sorts of autoimmunity. So it's, I'm just going to stay concerned. And of course, the microarray doesn't rule out DiGeorge.
Yeah.
So, and so many of our patients have no, especially infants of diabetic mothers, we just won't find any reason for them to have DiGeorge.
Adam, I just segued into your next slide. Sorry.
So atypical DiGeorge phenotype clinically fits DiGeorge syndrome with syndromic associations with facial, heart, parathyroid, and immune abnormalities, the thymic hypoplasia, but doesn't classically have that 22q11.2 deletion. Interestingly, can evolve into that similar phenotype to Omen syndrome with elevated IgE, eosinophilia, skin rash, lymphadenopathy, and they typically have alleloclonal T cell repertoires.
And I'll just interject here. Actually, the patients who have atypical have just as much 22q11 as the patients without atypical.
Okay.
And it seems like the phenotype can be pretty, there's a spectrum for what different patients will be having as part of their atypical DiGeorge phenotype. So kind of segueing additionally into gestational diabetes and embryopathy. So there's a lot of growing interest and focus on the uteroplacental environment with exposures to maternal non-communicable disease risk factors, hypertension, autoinflammatory diseases, and specifically diabetes. Diabetes has been a known potent human teratogen. We know just in pediatrics, journal Peds, diabetes is a significant risk factor for the fetus, spontaneous abortions, perinatal death, and malformations. And of course, later on in pregnancy, macrocephaly, IUGR, and then poor glycemic control after birth, and a predisposition to develop insulin resistance later in adulthood. But interestingly, in that time frame of blastogenesis, in the first kind of 4 weeks of the developing cells, that those sugars and insulin levels, the exact mechanism not precisely known, but plays a key role in altering biochemical and metabolic processes is the hypothesis, resulting in altered expression of developmental genes in the embryo, which they think results in the abnormal morphogenesis. Looking at the incidence of birth defects in newborns of diabetic women, it's approximately 3 to 5 times higher than among non-diabetics. The highest risk for malformations being reported in women with pregestational diabetes, so it was there to begin with, irrespective to the type. There's an intermediate risk reported for overweight women developing gestational diabetes, and the lowest risk being pregnant women with gestational who didn't have pre-diabetic markers, so pretty similar to the general population. And looking, again, mentioning the blastogenic malformations, gestational diabetes, it really seems, based on the phenotype expressions that we see in patients, to be affecting at that blastogenic period of development, with caudal dysgenesis obviously being kind of that board prep answer that we think of when we think of gestational diabetes and embryopathy. But thymus aplasia being a key thing that we wanted to point out here, and something that isn't is widely talked about. I see some questions.
Yeah, sorry. You keep going. Well, just because we only have a few more minutes, and I want to make sure Louise can comment on some of this stuff here.
Perfect. And this is actually, I think, from one of the studies that Dr. Markert was on. This was a paper that was actually looking at infants who received transplant and whether they went to needed a PICU admission with emergency or not. But looking at some of the just kind of demographic and data that was collected for this study, not even half were due to the 22q deletion, which was interesting, only 39%, but about 20%, 11 out of 59, were attributed to diabetic embryopathy for patients that were included in the study. So it's just a really large number. And I don't know if Dr. Markert wants to comment or say anything else on that, since she was involved.
It is very interesting, and there's another group as well that have no charge, no 22q11, not an infant of a diabetic mother, but still have some of the DeGeorge phenotype, and they also will have problems. So it's just.
Yeah, so I think the reason we chose, we want to talk about this case is because, yes, we're calling him DeGeorge, and we're attributing it, it's hard for when we tell mom DeGeorge and she wants to have another children and she wants to know what's the likelihood of this happening again. And we basically have told her, we believe this is related to her diabetic status. She's still a diabetic. She wants to know, does this mean all my children are going to have this problem, whatnot, And so I talked to her a lot about diabetic control and how we think it's important for embryonic development, or how we it's important, but how we think it's important for the thymus and things like this. But I wasn't able to answer all the questions in a specific detail, which is why I sent her to genetics. But this is how we're calling him, and how. Yeah. And so we're watching him and like an atypical DeGeorge. And so I guess the questions I have for you, Louise, are mostly the next steps. And we're worried about his, his ratios trending down, or his naive memory. And you're worried about his low levels of naive T cells. I'm, worried about him developing other problems of immune dysregulation. His IgE has been normal. His EOs have been fine. We tried to get Spectre typing this last visit just because, but it got canceled because of, bad weather. And I know, there's two sides. Some people, usually I get Spectre typing once in my DeGeorge patients, and then I follow it if they start acting funny, but I'm interested to hear, how often you recommend doing that. I think from a patient perspective, it's not always well covered from an insurance standpoint, and it doesn't sometimes change as much. And if it's reassuring, but I don't know. And then I was interested to see if other people were going to recommend other whole genome, or are we just all comfortable calling this infant of a diabetic mother contributing to the DeGeorge? And then we already talked about the thymus stuff.
And I just think this is an infant of a diabetic mother.
Okay,
and
so you would stop.
These levels are too low for safety in terms of autoimmune diseases going forward. So this is somebody that I think is reasonable to at least give the folks here at Duke information, so that if a transplant is needed, he would be in the line.
Okay. And so in this type of patient, what would need, if his count starts to continue to decline, or he's developed some type of autoimmunity, you would just make that direct referral at this point?
I mean, it just looks very suspicious to me right now. And the thing is, we have a long list, so it's you can get on the list. It's always
Right.
easy to go off, but it's harder to bump up. So
Okay,
it
great.
is something to consider.
Do you have any recommendations on the Spectre typing?
No, I don't do Spectre typing a whole lot. We used to do it, but right now we're sticking with the naive T cells.
Okay.
That sort of
Great. And then, we just added this in because I had another patient who was very similar, who had completed George from infant of a diabetic mother. But I just put this in here because this, as you talk about complete to George versus SCID, Dr. Haddad and Dr. Notarangelo both have these artificial thymic organoid platforms where they can help differentiate whether this is intrinsic or extrinsic defects. So I just put that up there as a reminder of people in case they have this problem early on and they're wondering, does this kid need a thymus or does this kid need a bone marrow? I just put that on a reminder. Obviously, this kid, we're not talking about that at this time, but I just put that as a reminder. Louise, someone wants to know if you could comment or explain why the T cell count correlates with a risk for autoimmunity.
Well, I know it does. And I think you just don't have enough T cells and T cell receptors to fight off the various problems that come along. If you just have a few clones, it's not enough. You need a good repertoire.
Okay. Okay, thank you. Adam, just read this slide and then I'll answer some of the other questions in the chat so that we can get moving on to our second case.
Perfect. Big takeaway points. Consider diabetic embryopathy as a cause of non-genetically defined T-cell lymphopenia, especially for other congenital abnormalities. It can be severe and picked up on the newborn screen. These babies can be severely immunocompromised and may warrant appropriate treatment, being prophylaxis, IgG, etc.
Great. I don't know what happened. Okay. Great. So just keep in mind, infant of a diabetic mother can cause severe T-cell lymphopenia. We can move on to Tamar's case, and then I'll try and answer any additional questions in the chat.
All right. Hi, everyone. Thanks, Kelly. And that was a case. So I'm going to be talking today about a patient with early onset recurrent multisystem inflammation. And my senior mentor is Dr. Janet Chou from Boston Children's Hospital. So I just want to start by giving a land acknowledgement. The University of Manitoba, where I work, is located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and the homeland of the Métis Nation. And acknowledging that I work with and for many Indigenous people. I respect the treaties made on the territories, acknowledge the harms and mistakes of the past, and we as a university community dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So the case I'm going to present today, I first met her when she was 8 months old, and she was referred because at 5 months old, she was very, very sick with what was diagnosed as group A strep sepsis with toxic shock syndrome. She had presented with severe multi-organ failure and required quite a prolonged PICU admission. So this, encapsulating everything about this initial presentation, it was sort of HLH-like, especially in retrospect. So she first presented to a peripheral emergency department in an adjacent province with viral-like symptoms, fever, rash, cough, congestion, but very quickly within a day or two progressed to becoming lethargic, respiratory failure, and required intubation. She was transferred to the PICU, and in the ICU had rhabdomyolysis, splenomegaly, acute kidney injury, ARDS. Investigations were consistent with bacterial pneumonia on chest x-ray initially. Blood culture quickly within 24 hours group A strep. She had a very high white blood count and also thrombocytopenia and anemia, and was noted to have very elevated liver enzymes peaking at about 9,000 units per liter, as well as hyperferritinemia peaking at about 12,000. And so it was seeming HLH-like, but the leukocytosis was atypical for that. And given the fact that she had bacteremia, didn't get specific targeted treatment at that point. She did have an extensive investigation for other causes of infection, including ETT cultures, full septic workup, lumbar puncture, viral studies, HIV, pertussis, blastomycosis, given that she was from Ontario. She had an immune workup at that time as well, which just showed mildly decreased B cells and NK cells, but really close to the lower limit of normal. So her treatment was generally supportive and ultimately recovered spontaneously with just supportive care and antibiotics. So when I saw her in clinic, the past history, social family history was really unremarkable. She lived with her parents and extended family on a small reservation in Ontario, 10 people in a one-bedroom home. So lots of risk factors for household crowding, viral infections, sort of typical situation. And parents were of OG Cree background with no reported consanguinity. She also had a 6-year-old brother who was likely a maternal half-brother who'd been very healthy, no history of infection or severe illness. And within the immediate and extended family history, nothing to suggest immune deficiency, HLH, early childhood death, or genetic conditions. So we sent her home. We were going to follow up in a year, but I got a call 5 months later from the PICU next door in Ontario. The patient was now 13 months old, and she was admitted with another second sepsis-like multi-organ dysfunction presentation. So this episode actually started 1 week after she received her 1-year-old immunizations, which include the live virus MMR vaccine. She presented with fever, cough, rhinorrhea, which quickly progressed to respiratory failure. She had hepatosplenomegaly, rhabdomyolysis, and rash. And she was very, very sick, again, with this HLH-like picture. She needed 6 weeks in the ICU. Again, she had marked leukocytosis, as well as very notable monocytosis, with anemia, thrombocytopenia, elevated liver enzymes, high ferritin, although not as high as the previous episode. Because HLH was considered as well as JMML, given the monocytosis, she had a bone marrow aspirate, which showed a hypercellular marrow, no evidence of cancer, and a few hemophagocytes. She had a liver biopsy, which showed nonspecific inflammation, and the stains were negative for viruses. Interestingly, she had a nasopharyngeal aspirate, and the PCR showed vaccine strain measles, as well as IgM2 positive to measles. In addition, she was found to have low-level EBV PCR in her blood. So ultimately, with all the investigations and treatment, she was diagnosed with ARDS with multi-organ dysfunction on account of vaccine strain measles, possibly with a contribution versus bystander effect from EBV viremia. And at this point, immune deficiency was raised again as a possible underlying predisposing risk factor. Her treatment in the ICU was ribavirin, vitamin A for the measles. She did also receive methylprednisone and a dose of higher dose IVIG. So when we saw her the second time after the second HLH-like episode, she had some of her initial immune investigations repeated and some additional investigations. So again, she had normal immune globulins. While she was acutely unwell in the ICU, her T cells were elevated, and I've included the numbers there. But normal B and NK cells, and then upon recovery, the T cells had normalized, and she had mildly reduced B and NK cells, which had been seen previously as well. She also had some functional testing for HLH and HLH-like conditions. So she had CD107A expression that was normal, perforin expression, soluble IL-2 receptor. She had a neutrophil oxidative burst done, as well as flow cytometry markers for leukocyte adhesion deficiency. And then she had testing for mitogen proliferation, and all of this testing was normal. So she also had some rapid turnaround time genetic testing, given how sick she was. She had an HLH autoinflammatory panel, which was not revealing. She had trio exome sequencing sent to GeneDx, again, not revealing. And then she had a microarray, which showed 11% regions of homozygosity. And that's not atypical for patients that we see, particularly from small communities like this patient, even though there was no reported consanguinity on history. So she was eventually transferred to our center for ongoing evaluation and follow-up after her acute recovery. And over the next 1.5 years that I followed her, she continued to have elevated liver enzymes, although they were improving. She had imaging evidence of cirrhosis and ongoing low levels of elevated ESR and ferritin. NK cells continued to be mildly low, but the B cells had normalized, and she persistently had low level of EBV viremia. She was seen by hepatology, and they felt that the hepatitis was a bystander effect because of immune dysregulation. She had a repeat liver biopsy. Again, stains were negative for EBV and other viruses, and so there was no evidence in this case of chronic active EBV or something like that. Periodically, she would have intermittent thrush and bad candidal diaper rashes, but she was clinically very well. She was not getting frequently ill. She wasn't getting other apparent opportunistic infections. However, given the fact that she'd now had 2 HLH-like episodes with very prolonged ICU admissions, I did make a referral to our BMT team. But given that there was no diagnosis, she seemed to recover from these episodes without any targeted treatment. And also given this sort of the cirrhosis, unknown etiology, they were a little bit reluctant, but even making them even more reluctant was the fact that her brother was not actually a full sibling. There was no familial match, no unrelated match in the registry. So the best option would have been her father. And there were a lot of social challenges in this case that made it concerning to consider the possibility of transplant in terms of just getting the patient in from the remote community and follow up. So at that point, I actually sent an email to Dr. Chou and Dr. Geha at Boston Children's Hospital to get their opinion. And at the time, I had actually been looking at the regions of homozygosity for immune-related genes, and I was particularly interested in STAT2, which is a transcription factor involved in viral immunity, because I'd reviewed a case report of a patient with STAT2 deficiency who presented with HLH after MMR vaccination, similar to our patient. But as it turned out, that was not the diagnosis, but that's sort of what prompted the email, because I'd seen a paper from their group about that. So meanwhile, while I had reached out to them, our patient presented with yet another HLH-like episode. So this time she was 33 months old. She presented with dyspnea, lethargy, fever, and rapidly had progressed to an ARDS picture again. She also had acute kidney injury, splenomegaly, and this time seizures. Investigation showed bicytopenia, again, leukocytosis with neutrophilia and monocytosis, transaminitis, elevated ferritin, and she was found to be positive on NP aspirate for influenza B, as well as MSSA from her ETT cultures. In this case, when she was first seen in the ICU, they suspected HLH and had treated her with high-dose dexamethasone and also supportive care for flu and a dose of IVIG. Again, stem cell transplant team was consulted, but unfortunately, following this episode, had a severe neurologic injury. And although she'd previously been developing fairly normally, meeting her milestones, was ambulatory verbal, became non-ambulatory, non-verbal, unable to feed safely orally, and required G-tube feeding. And so was, amongst her other risk factors, was not felt to be a good candidate for transplant at the time. Imaging findings of her brain showed restricted diffusion with increased T2 signal intensity in the cortex of the frontal, parietal, and temporal lobes bilaterally, and increased T2 signal intensity in the subcortical and deep white matter of these lobes. No evidence of bleeds or vascular abnormalities. So this is just a summary of our case so far. So a now 3-year-old girl with 3 HLH-like episodes. The first one in the context of group A strep bacteremia, the second after 1-year-old immunizations with evidence of vaccine strain measles and EBV, and the third in the context of influenza B and Staph aureus. And after the second HLH-like episode, this sort of liver disease that was felt to be immune-mediated, and after the third episode, neurologic injuries with fever and severe cognitive impairment. So I'm not monitoring the chat here, and I don't know if people have ideas about possible diagnosis, what further investigations, and what kind of management
There are only 2 questions so far in the chat, and one was asking about Hlh-directed treatment to control the immune dysregulation or just supportive treatment, and it seems like you addressed that throughout the cases. But if you want to add anything else, do you remember if they needed anything else for HLH?
Yeah, I mean, all they got was like at times IVIG, like 1 to 2 grams per kilo, and then 1 dose, a couple doses of high dose dexamethasone. But ultimately, it sort of recovered on its own.
Okay, so no, like, yeah. And then the other comment was increased autoimmunity in patients with lymphopenia. Oh, that's related to our other.
Okay.
Someone mentioned considering interferonopathies.
Okay. That's a great point. So I'm just going to move along just so you can hear about the interesting diagnosis that was made. And we did not do IL-18 level. So in the meantime, I did get an email back from Dr. Chou and Dr. Geha about an exome reanalysis that had identified a homozygous missense mutation in a gene called ZNFX1 that had a high CAD score. So they also sent over this paper from Nature Cell Biology from 2019, and this was studying the function of ZNFX1 in mice. And they showed that viral infection induces the expression of ZNFX1, which is an interferon-stimulated gene. They showed that ZNFX1 is essential for innate anti-RNA virus immune response in vitro and in vivo because it initiates interferon-based antiviral responses, directly binds to viral RNA, and localizes to mitochondria and interacts with MAV, which is mitochondrial antiviral signaling protein. And importantly, they showed that ZNFX1-mediated signaling is independent of RIG1 and MDA5, which are known to be important in the innate antiviral immune response. So this is a graphic from that paper that shows the working model of how the mitochondria-localized ZNFX1 functions as a double-stranded RNA sensor and initiates antiviral responses through MAVs. Upon RNA virus infection, ZNFX1 induces a type 1 interferon response by interacting with MAVs in the early stage, and this primes the expression of a number of interferon-stimulated genes, including RIG1 and MDA5. The induced sensors then further enhance the antiviral response by amplifying ISG expression. And the key findings from this paper were that ZNFX1 is an important sensor and inducer of interferons and ISGs in the early stages of viral infection, but also that it regulates the antiviral response later on through its regulation of other ISGs like RIG1 and MDA5. So just as a quick review, so we all know that interferons are synthesized upon pathogen detection, and they trigger a signaling cascade that leads to transcriptional regulation of hundreds of ISGs, and that elicits an antiviral state within cells. And one of the important triggers for a type 1 interferon response is recognition of viral nucleic acids. Of course, interferons and ISGs are also important mediators of inflammatory responses during bacterial infections, and an illustration of that is in Mendelian susceptibility to mycobacterial disease, where there's susceptibility to weakly virulent mycobacteria if you have a defect in either the production or response to interferon gamma. And patients who have inborn errors of type 1 interferons, where there's imbalanced interferon production, either have increased inflammation and or increased susceptibility to viral infections, both of which we saw in our patient, and someone had suggested in the chat about an interferonopathy. So that was right on. ZNFX1 is shown to be an interferon-stimulated double-stranded RNA sensor that is able to restrict RNA virus replication in mice, but the role in human response is not known. And so this led to a collaboration between Dr. Chou's group in Boston and the group in Zurich, Switzerland, to study 15 patients from 8 families with an autosomal recessive immune deficiency with similar features to our patients. And they found that in all these patients, there were homozygous and compound heterozygous ZNFX1 variants in all the patients, and there were 2 siblings who had passed away that couldn't be presumed to have the same mutations. And these patients all presented with early onset systemic severe acute inflammatory disease associated with cytopenias and major organ dysfunction of the liver, brain, kidneys, and lungs, just like our patient. Infection-triggered inflammation was the initial presentation in 9 out of 15 patients and occurred in 12 out of 15 at some point in the disease. And of those for whom diagnostic criteria for HLH was elicited, 6 out of 12 patients met the criteria. In some cases, there was spontaneous remission of their systemic inflammation, although in at least one patient, ruxolitinib was used with a sort of temporal effect, and one patient received a transplant and was well afterwards. The severe infections in the patients in the study were caused by negative single-strand RNA viruses or DNA viruses, and the mortality was very high in this group of patients. 11 out of 15 died in childhood, and 7 of them at under 3 months of age. So this is the pedigrees from the families included in the study, and you can see where the different mutations were. 5 of the mutations were truncating variants and missense variants, and all of the variants were predicted to be deleterious by a variety of different predictive tools. So the experimental investigation of the role of Zfx1. It was demonstrated that stimulation of Zfx1 deficient patient-derived primary cells with synthetic double-stranded nucleic acid was associated with a deregulated pattern of expression of ISGs, alterations in the half-life of the mRNA of ISGs, and poor clearance of viral infections. They studied VSV and influenza by monocytes. And Zfx1 mRNA was ubiquitously expressed in human tissues, but mostly in the hematopoietic system, and got quickly upregulated in fibroblasts after stimulation with transfected poly-IC or poly-DADT. So the conclusions from this study were that Zfx1 is an important regulator of the response to double-stranded nucleic acid stimuli following viral infections. And it's important for both sensing the nucleic acids and in post-transcriptional regulation of ISGs. And it also predisposes to severe viral infections as well as a multi-system inflammatory disease. So in addition to the study that included our patient that was published in JACI in 2021 that I just showed you, another group reported on 4 patients who had presented with intermittent monocytosis and mycobacterial disease, the index patients either with BCGiosis or disseminated TB. And of those 4 patients, 2 actually also had recurrent unexplained fever, thrombocytopenia, and organomegaly, like what we saw in our patient. And interestingly, the patient's production of and response to interferon gamma in the study was intact. And then finally, just in 2022, this report was published, reporting an additional 9 patients from 7 families with 6 novel homozygous Zfx1 variants. These were patients from the Middle East. And again, a spectrum of inflammatory and multi-organ inflammatory presentation. So just to summarize human Zfx1 deficiency, Zfx1 is an ISG and its expression is upregulated by the JAK-STAT signaling pathway. It's got a role in antiviral immunity, and it also participates in the post-transcriptional regulation of ISG mRNA stability. It's essential. It seems to have a role in monocyte homeostasis as well as immunity against mycobacteria, but a lot of that needs to be further described. And 28 patients have been reported with this novel immune deficiency to date, 15 reported by Vavasori and Chou, 4 from Lavoyer and Nijos, and 9 from Alaubethany and Westenberger. And this is just a summary of some of the clinical features. So these are the references, and I just want to acknowledge Dr. Chou and her group at Boston Children's Hospital for all their help with my patient's case, and then the group in Switzerland for their role in this as well, and of course all the many authors on this paper.
That's a great case. Maybe Dr. Chou can comment on, there's a great question about specifically the mechanism of the Hlh component, besides just, the multi-systemic, but like the pathway involved, and maybe speculate on that mechanism.
Yeah, that's an excellent question. There isn't a clear answer, to be frank. What we did find was the signaling downstream of certain TLR receptors, like TLR3, was actually reduced, which would give you some idea of the susceptibility to viruses, but that the expression of certain interferon stimulated genes after other stimuli like cytosolic DNA was actually increased. So it appears that it almost acts as a rheostat in terms of sort of modulating sort of a good response downstream of some, whilst regulating, too much of the other. It's even its structural localization of this protein is not, I would say, fully understood. It's in the stress granules, as Tamar mentioned, in the mitochondria as another. So most likely it's acting as a scaffolding, but there's a ton of work that needs to be done. I know that the Zurich group is working on that, as I'm sure others are.
And thank you. That's it's going to be tough to figure that out, but will be greatly insightful if we do. Question from Scott Canna about strep and was it a red herring? Do you think, Tamar?
Yeah, so I'm not sure, because I don't understand a lot about Zfx1 and its function, but I know that the it seems to clearly have a role in antiviral immunity. The patient did have some viral-like prodrome prior to having the bacteremia, but then the group that just published the report of the 9 additional patients reported also some bacterial and fungal infections, and our patient did have recurrent oral thrush. And there's also this DNA viruses, and so it seems like perhaps it's the ongoing lack of control of systemic inflammation may have some role to play, in addition to the lack of sensing of the RNA. I'm not sure, but I'm really
I think that's right, Tamar, and also that certain bacteria obviously can activate, group A strep, for instance, and can activate, type 1 interferon signaling, not necessarily through specific TLRs. So it may just be, as you're sort of alluding to, a convergence of activation of, let's say, type 1 interferon, stimulated genes.
Mm-hmm. Not to belabor the point about us not being clear about the HLH episodes, but someone was asking about suggestions on how to treat them. Like if this patient has another episode, do we think we'll treat it differently now that we know the mutation, or just still steroids, dexamethasone?
Yeah, I've been wondering about that, and if there's a role for a JAK inhibitor. I've been reluctant to try to use that, given that she's not getting infections now, really, and I don't want to predispose her to infections by giving her that. And she also has this ongoing EBV viremia. But I might. And she remains on ongoing IVIG, and I'm not sure if that's doing anything, but we feel like we're doing something.
Well, someone just asked that question. At what point would you DC the IVIG?
Yeah, we have her on subcutaneous immune globulin because she's in a remote community, and so we want to keep her out of hospital. And after she got sick from the vaccine strain measles, we said no more live immunizations. And then we were also not sure if she had, say some sort of risk from just immunizations in general. So she's been on chronic subcutaneous immune globulin, and we've just kept her on it for now.
Mm-hmm. Rebecca Marsh is voting for a JAK inhibitor. It's probably not as bad as high dose of steroids, especially if it's a short course with a JAK inhibitor. Well, that's a great case.
Yeah, if anyone has any ideas for treatment or short-term or long-term, please feel free to email me, because she's sort of, I'm not really quite sure what to do with her. We're just following her over time, and I'm just waiting for the next call.
Yeah, the spectrum is tricky, right? Because the cohort that's presented in the PNAS paper is somewhat different, and then the third cohort you presented was almost a fusion of the prior 2 papers. Mm-hmm. So I feel like the treatment almost gets tailored to sort of the phenotype, and I don't know why the phenotypes are so different, whether it's the differences in the exposures or the genetic background, although all of these, the first 2 papers anyway, had, kindreds from multiple different places across the world. But as of now, I feel like, it's just has to be tailored to each individual's sort of like which pathway seems most dysregulated in them.
Yeah. Thank you, guys. I know we're already at basically 9 o'clock. I don't know if Morgan is still here. We have the other few slides loaded. Okay. So we usually try to spend for the last 5 minutes of the webinars just reviewing a hot article that just came out. And this article definitely requires a lot more to unpack. So I encourage you to download the article. And I also encourage you to download all the extra supplementals, because it took me a while to really figure out what the heck was going on. But it just came out in Jackie, and it's super interesting, and a lot of bioinformatics and things like that. But I think it gives us a lot of insight of where our future is going. And so if we just have a few minutes quickly to talk about this article. So they had 3 objectives. They wanted to systematically review terms that were in the Human Phenotype Ontology website for the depiction of IEIs, and then expand what is in HPO in order to basically be more comprehensive, to include our IEI diseases. So they wanted a more comprehensive set of terms. And then they tried to re-annotate the words and options to use, so the HPO terms, to make it so it's more user-friendly for people like us as clinical immunologists, and to provide more accurate and standardized phenotypic descriptions. So if you're wondering what all these acronyms mean, I'm going to get to them in the next slide. But I didn't know anything about HPO until I read this article, and I was like, what is going on? But it's very, very interesting. So they have some really elaborate methods, and they used a 2-tier expert review and machine learning, essentially, to re-annotate the way we think about these phenotypes in order to use a system to try and help us better categorize, I guess, our IEIs. And this was a collaboration of expert clinicians, geneticists, bioinformatic people, and researchers working on IEIs. So this is a website, Human Phenotype Ontology, where you can go in and people use it in a variety of different, like geneticists use it a lot. It was first established and published in 2008. It is the most comprehensive deep phenotyping resource for rare diseases, for clinicians, researchers, everybody, and EHRs. So the electronic health records are also using it. And you can basically use it as a search function to put things in there and try and figure out what diseases you need to be thinking about. It's a community-based tool to describe phenotypic abnormalities that we're commonly seeing. So like low set ears, you can put that in there. Hyperextensibility, or it's used by the 100,000 Genomes Project, the NIH Undiagnosed Disease Network, the International Undiagnosed Disease Network, and RD Connect, all these other programs, they use it. And so it works really well in certain fields. But I think it has, what the readers, the authors talk about, is it hasn't been widely used by clinical immunologists, specifically in IEIs, because our terminology is very specific. And it's not generally applicable to the terms that they have in this database. So to try and bridge our field with them, this work group basically worked very hard to try and make it more applicable. And so while we have 10 different tables in our IUIS, they try to focus on just 4 different tables: immune deficiencies affecting cellular and humoral immunity, predominantly antibody defects, immune dysregulation, and autoinflammatory disorders. And so they looked at those specific 4 areas, and then they looked at the terms and used this learning tool called the Neural Concept Recognizer, which has been validated. And then they looked at specific case reports or initial articles describing those diseases and pulled out common words that they thought really characterized those diseases. And then they created these specific summaries with HPO terms, and they had them in these summaries, and they would rank them by frequency across the articles. So they basically tried to come up with a list of terms that characterize each disease, and then they mined them and extracted those terms. And then they had a 2-tier expert review system, and all the people who reviewed those, any term that was 80% or above in common that was selected for those diseases were used and then put into HPO. And they were asked to indicate if this term was either a true phenotype. So if they thought, for instance, ZFNX was multi-system inflammation, and everybody thought that then it would be added to that as a true phenotype. So that's what they did. And then in a more elaborate way, they went back through and they had 4 main branches that they completely restructured. This was the metabolism, homeostasis, cardiovascular, skin, and then immune system. And they restructured those 4 areas. And then they replaced a whole bunch of terms. And then they added 57 new terms, such as things like recurrent fever, which never was in the HPO, or unusual infection, or abnormality of IG. And they made all these new terms that now can apply to our IEI diseases. So they tried to expand basically what HPO's user ability was. And then they made this case checking mechanism to look, and they had a clinical history. And this is just basically to show the work through of what they did. And they wanted to see if it was validated or not. So they had this case, they went through, came up with different phenotypes. They looked to see before annotation if it would have been popped up, and then after annotation, if it improved because of the new terms that they could use because of all the new things that were re-annotated. And it was very helpful. Before annotation and after re-annotation, we are now identifying more diseases in the IEI. And then, so the key results were they re-annotated basically 73 diseases from just those 4 subgroups. With HPO terms, which resulted in a 4.7-fold increase in the number of phenotypic terms. And so this is the very first time this has ever been done specifically with IEIs. And, as fast as we know the IUIS is exploding with all these new genes, at least now it's going to be a more user-friendly for other people who are using HPO, but also we'll be able to collaborate better and it enhances the precision of our disease annotation so that we can better classify these diseases. Adrian said, HPO terms are used by many genetic testing companies to compile lists of genes to be reviewed during exome. Think of it as keywords. It's great that they're adding this specific to HPO, IEI, and it will increase the sensitivity of finding mutations. And I saw a pop-up saying Kate Sullivan asked a question, but I can't see it. I don't know. Sorry. I cannot see it. I'm sorry, Kate. But yes, she wrote such important work. We all use it. It's just working behind the scenes for all of our whole exome analyses. So pull the article, read it about 5 times because it takes that long to really figure out all this craziness that he did. It looks like a lot of work. And I'm sure with this just being the first 4 subgroups that, this is the first of many papers like this. But it was really exciting to see. Thank you all for spending so much time with us tonight. And we look forward to seeing you hopefully in person. But if not, it's a hybrid format at the annual meeting. Have a good night and stay safe and healthy.